Fine. So today I'm going to talk about the pediatric rashes, children who present with different type of rashes in the emergency department. And usually, I mean, I've seen that many times doctors just freak out when they see kids with different type of rashes because they are not able to make a diagnosis in a short period of time, and they just wonder what they are dealing with. So in this 1 hour, I will try to make your life simplified by trying to give you a sort of a methodical approach so that you can apply it to any child who presents with any type of rash. And in most of the cases, you will see that you will be able to make a diagnosis if you follow a sort of a methodical, systematic approach. So for those of you who probably won't stay for the whole 1 hour, few things that I just want to like sort of put in a nutshell that can help you. That is, the first thing is that there are a few things when you are dealing with any child who has got a rash, is that you have to ask the right question, you have to learn the visual cues, and if you have got these two things right, then you can make the right diagnosis. But with that, any child who you are you seeing with a rash, you always remember, you always need to have a good light source to examine the child, and preferably always examine them with a magnifying glass. So this is very, very important, that whenever you are dealing with a child with a rash, you have to ask the right question, and in a moment I will tell you what those right questions are. You have to learn the visual cues, like how would you sort of describe the rash, and based on these two things, in most of the cases you would be able to make the right diagnosis. And as I said, like, the most important thing when you're examining these is you need to have a good light source. So if you got this bedside examination light, use that, and use a 3x or a 5x magnifying glass. It should be there in your pocket all the time, so that it helps you in sort of examining these rashes. And remember, when you examine a child who's got rash at any part of the body, never ever forget to examine the oral cavity. This is very, very important. Always examine the oral cavity. Even if they say there's nothing over there, do examine it. Now, when any type of rash presents in the ED, there are a few things. Number one is those type of rashes where you have to act now, like that is an emergency situation. Then there is another group of rashes where probably it's not an emergency, but there might be a sort of an element of urgency. You can just deal with them as soon as possible. And the third category is where ideally these kids should not be coming to the ED at all. That should be, the primary care provider should be able to deal them at the primary care. But, I mean, these are those rashes that even if you don't deal with them, it's not going to do any harm to the child. So the first, group of rashes where you have to act now, any rash, whether it's a maculopapular, blanching, non-blanching, whatever, but any rash which has got a deranged vitals, like where it's associated with shock, let's say tachycardia, decreased blood pressure, decreased cap refill time, irrespective of whatever is causing that rash, wherever that rash is coming from, you have to act there and then. And again, I don't need to tell you that are your A, B, C, D, E's that you have to do with that. Then any rash which presents with airway compromise. So a child who has got a rash and he's presenting with a swollen throat or a stridor or difficulty in breathing, you have to act there. And then you might be dealing with, let's say, anaphylaxis or something like that, severe allergic reaction. Or any child who had severe burns and they developed a rash a few days afterwards, and now they are coming back with a rash that can be a staphylococcal, leading to a toxic shock syndrome or something. Again, these are the types of rashes where you have act there and then. So irrespective, you're not making any diagnosis or something, but if a rash presents with these things, you have to act there and then, and that is your ABC disease. Then where you can, like, by some time, no emergency, but let's say an element of urgency, you can deal it the next 2-3 hours, 4 hours. That are all type of palpable rashes. So all those rashes where you can, you can feel for those rashes. That would include different type of vasculitic rashes. That would include different type of maculopapular rashes. I will go into the detail in a short moment of time. Or those rashes which have got different shades and color, a mix of different shades and color. And these are those rashes, polymorphous type of rashes, where there would be a sort of a tricky diagnosis, underlying diagnosis, some form of immune reaction, abnormal immune reaction going on. So rashes which have got where you see different colors, different shades, pinkish, brownish, purplish, then again there is an element of urgency over there. And then all those rashes, blanching rashes which have got normal vitals, ideally they should not present to ED unless until there is other reason. some other reason apart from the rash for which they are coming in. These are mostly viral exanthems. There are more than 200 different types of viruses that can give you these types of rashes. And they are associated with these self-limiting viral illnesses, and ideally they shouldn't present to the ED. And certain type of papular rashes, which are usually delayed hypersensitivity reactions to different types of things, not of much clinical significance. So by and large, any child who comes to the ED, the first thing is whether, irrespective, you're not make a diagnosis, the thing is that whether you need to act there and then, emergency, or whether there is an element of urgency where it can be dealt as soon as possible, or where ideally it shouldn't present to the ED. So having said that, the next thing is, you have to, as I told you earlier, you have to ask the right questions. You have to learn the visual cues. So obviously all of you know how to take a detailed history, but usually in ED you don't have time to go into a very detailed history asking about each and everything. You cannot waste next 30-40 minutes on taking detailed history from everyone. So there are a few things like a focused history, and there are like 5-6 things which you have to focus on for any child who presents with a rash. I mean, you can just remember these things on tip of your fingers. Any child who presents with a rash, the first thing is it associated with fever? Is there any like accompanying fever before that or after that or during that? So an element of fever, whether it's there with the rash or not, this should be your first question. Second question should be about drugs. If the child is currently taking any drugs, because certain types of drugs might be associated with rashes. It can present in different forms, like immediate drug reactions or delayed hypersensitivity reactions. Some of the drugs are quite notorious for producing different types of reactions, like some of the antibiotics can do that. Some of the anti-epileptic medications are known for producing drug rashes. So ask about any medication. It's not necessarily that you should say, well, this drug is not associated with this type of reaction. Something. Just ask if they have been taking any medication in the recent past or not. Ask about the history of travel. This is also important because travel to certain types of area might be associated with certain types of exposures and rashes. So somebody who's been, like, for example, going and doing camping or something, tick bites, Lyme disease, these type of rashes can be associated with travel to like forests or camping tours, things like that. Always asked about if they've got any allergies or exposures, if they have got any like known drug allergy or known let's say dietary allergy or allergy to anything. So ask about a history of allergies, or whether they've been recently exposed to anything, let's say certain type of plants or chemicals, things like that. Ask about if there are any contacts, like any contact with any other child or person who had a rash. This is important. If there are, let's say, if there are household members who have got the same type of rash, like scabies, or recently we've been talking about monkeypox and things like that. So if there has been an contact with someone else who had a similar rash, so ask about the contact. Ask about recent illnesses in the last like 1 to 2 months. If they had certain types of illnesses, sometimes these illnesses might lead to appearance of rashes later on. So ask and any associated features. So if they have got any features of any sort of associated other symptomatology, or you find on examination that there are other features of illness like hepatosplenomegaly, or let's say respiratory problems or GI problems, blah blah, it could be anything, I mean, when you're examining. So any associated features. So these are the things that you must ask in any child who presents with any type of rash. So you should remember it on your fingertips. But fever, drugs, travel, allergies or exposures, contact, and recent illnesses. It's very, very important. Then once you have asked the right questions like a focus history, then it's important to learn the visual cues. And in visual cues, there are 4 things that you should mention about any rash that you see. And there are 4 things: are size and shape, distribution, pattern, and color. So let's talk about them one by one. So when we talk about size and shape, it's very important that you describe the rash. It's not simply saying somebody has got a rash. I mean, what sort of rash it is. And there are certain medical terms which are used when you describe any rash. So some of the common terms, I mean, the list is quite a big one, but like the common one is macule. So macule is basically a lesion which is not raised above the skin level. So you cannot feel for it. So it would be a pink or a red or a hyperpigmented or hyperpigmented spot on the skin, which is usually around less than 1 centimeter, and it is not raised. So if you feel it with the with your hand, you'll feel that it's not raised as compared to the rest of the skin. So a macule is a term so you should use if you feel like the rash is not palpable, you cannot feel it, and it's a 1 centimeter and it's got like any color. So that would be a macule. A raised small bump which is around 0.5 centimeter, not more than that, and it's a solid, that we call it as a papule. If the same solid bump is filled with clear fluid, we call it vesicle, and if it is filled with pus, we call it a pustule. So you have to use these terms. If you see like sort of a small bump, if it's a clear one, like a solid one, nothing, you say it's a papule, and the rash would be papular rash. If it is filled with clear fluid, well, you call it a vesicle or vesicular rash. If it is filled with pus, you call it a pustule, or it would be a pustular rash. Or sometimes you might see a combination. Some of them are papules, some of them are vesicles, some of them might be pustules, depending on the underlying illness. Then we use other terms as well. If let's say a macule is a large one, and we call it a plaque. If it is sort of is slightly edematous and raised, we call it a wheal as well. And if there is some form of dried crust on top of it, we call that it's a crusted lesion. If it's got very fine sort of a scales, we call it as a scale or a scaly lesion. And if you feel like the papule or the pustule or the vesicle has been has burst open and there is a raw surface, we call it an erosion. So these are the different types of terms. So you need to know what you are dealing with and describe the rash in its size and shape. So predominantly, if you see that there are pinkish spots with some raised bumps, solid, you call it the maculopapular rash. If it is like small papules and some of them are filled with clear fluid, you will call it a papulovesicular or plain vesicular rash. If they are pustules, you will call it a pustular rash. So describe each rash in its size and shape. The next thing, once you have described the size and shape, is the distribution of the rash. Distribution is very, very important because you need to know if it is a localized or generalized. Let's say a rash, irrespective whether it's a macular, maculopapular, papulovesicular, nodular, whatever. If it is just limited to one anatomical area, let's say face or chest or a single limb, we call it a localized rash. If it is spread beyond two anatomical areas, we call it generalized rash. So distribution is very important, whether it's a localized, whether it's a generalized. Then you can further say whether it's symmetric or asymmetric. A symmetric rash would be sort of equally distributed along the center line of the body. And asymmetric is usually on one side of the body. Similarly, whether it is predominantly, with some experience, you might be able to say whether it's predominantly affecting the flexural surfaces or the extensor surfaces. So let's say, for example, on the upper limbs, the anterior part of the upper limbs is flexural, the posterior part is extensor. On the lower limbs, it's the opposite. The outer and the anterior parts are extensor surfaces, the posterior part are flexor surfaces. So try to mention whether this is predominantly affecting the flexural surface or the extensor surface, or sometimes both as well. Again, whether it is mostly localized toward the center of the body, like mostly distributed around the torso, which we call as centripetal, or it might be centrifugal, like where it is mostly at the peripheries, acral rashes, like predominantly affecting the hands and the feet and the ankles, or it is predominantly, let's say, affecting the neck, the face, the chest and the abdomen, the back. That would be a more of a centralized rash. So centralized versus peripheral. And similarly, whether there is a coalescing pattern or a planar. Coalescing pattern are where, the rashes try to, patches are trying to merge into one another. So let's say discrete lesions are where every lesion is separate from one another. Some of them you might see that they are trying to merge into one another. So that would be a coalescing pattern. So see what is the distribution in terms of localized, generalized, symmetric or asymmetric, whether flexural or extensor surfaces are involved, whether it's more of a central thing or peripheral thing, and whether it's coalescing pattern or a planar distribution. So again, size and shape, and then you talk about the distribution of the rash as well. The third thing, after you have mentioned about the distribution, is the pattern of the rash. So pattern of the rash is, again, some rashes might be quite discrete, where you see every point is different. Some of them are polymorphous, where you see more than two types of shapes in the same rash. For example, if a rash has got some papules, some vesicles, some nodules, that would be a polymorphous rash, because there are, poly means many and morphous means morphology, shapes. So if you see in a rash that there are different types of shapes of the individual lesions, then it's a polymorphous rash. And polymorphous rash, again, as if you know the pattern, they are associated with certain types of conditions. We'll talk about them in the coming slides. Some of the lesions might be in the form of ring. Some of them, they might be serpentine, just like a serpent. So describe the pattern, if it makes any pattern. Some of the rashes are in the form of a Christmas tree. So you look at, and then you try to see if it is making any pattern or it's not making any pattern. So just mention if you see something is strikingly similar to some object, just describe that. And last but not the least is the color. So color depends, depending whether you see it's a pinkish rash, it's a bright red rash, it's a purplish rash, it's a brown rash, it's a golden yellow colored rash, or it's a mix of different colors. So you describe that this is predominantly a bright pink rash, or let's say a brown rash, or a rash with pinkish component and some golden yellow component as well, or it's a purplish color in the center. So describe this thing. So in the visual clues, you talk about whether the rash is macular, maculopapular, vesicular, nodular, whatever, okay, depending on whatever you see. You talk about the distribution, whether it's localized or generalized, whether it's peripheral or central, whether it's symmetric or asymmetric, whether it's coalescing or discrete. So you talk about these things. Like, for example, if you see here in this third picture right down, the one, you can see that few of the lesions are sort of combined with one another on the left side. So that is a coalescing pattern. So there are discrete lesions as well. So in the same rash, you might see that there's a mix of discrete as well as coalescing pattern. So this you have to describe whenever you are examining a patient presenting with rash. So you have asked the right questions and you have described the rash, with its all these visual clues. Then it becomes easy for you to diagnose that. For example, look at this rash. Okay, so this is an infant who has got a rash. Predominantly in this picture, you can see that it's appeared at the back. So let's say you have to ask the right question. So if this child presents to you and you ask the right question, I told you there are a few things that you ask. So let's say you asked about fever and the parents say, yes, this child is febrile. He's running a temperature of, let's say, 38 to 38.5 degrees Celsius for the last 2 to 3 days. Has he been taking any medication? Yes, they've been giving him paracetamol for the last 2-3 days because he's febrile. Has he traveled anywhere? Again, you ask this question. No travel in the last few days, few weeks, whatever. Is he known to have any allergies or any exposure? They say no, not at all. Are there any contacts, who might have? Yeah, they say in terms of contact, he hadn't had any contact with somebody who's got rash, but further to that, they say an elder sibling has got cold. Any recent illness in the last 2 to 3 months? None. So once you have taken this, then you describe this rash with the visual clues. So as I told you that there are 4 things that you describe: the size, the site and shape, the distribution, the pattern, the color. So looking at this rash, I don't know how much clear it is showing up on your screens, but if you look, it looks very fine, predominantly maculopapular. So you can see there are a few patches of bright pinkish colored lesions, which are probably macules, and then there are very fine bumps, solid bumps here and there, macules. So because this rash has got both macules and papules, we call it a predominantly maculopapular, a fine maculopapular lesion, which at the moment you can see on the trunk. So it seems like it's symmetric because it's equally distributed on both sides of the center line. It probably is generalized because you can see it's on the trunk, though the picture doesn't show it on the limbs, but probably if you magnify it, you probably would see that it's present on the proximal limbs as well. So it's predominantly central because it's more close to the center of the body. Some of the lesions are even coalescing. So if there is a I don't know if you can see on the back, there are a few patches which feel like they have coalesced, like sort of merged into one another. So there is a coalescing pattern, and there is a discrete, like some of the lesions are discrete as well, and the color is pink or bright pink. So with this presentation, a child who is febrile, who has got this maculopapular rash and predominantly central distribution, hasn't been exposed to anything, no history of allergies, no history of travel. Most of these are viral rashes. So as I told you earlier, there are more than 200 types of viruses which can give the same type of eruptions. Few of them are notifiable as well, especially like measles, rubella, etc. But again, there would be either an exposure to a similar case, or there might be history of unvaccination. But by and large, these are viral exanthems. So we use the word viral exanthem rather than being specific what virus has caused it. There's no point in running after which virus has caused it unless and until you are particularly looking for something. As I told you earlier, that in every child always with rash, always examine the oral cavity. Let's say with a similar case, if you open the mouth and you see that there are like sort of a whitish spots on the buccal mucosa, let's say where the second molars are, then probably you would be started thinking of measles. Like measles is also a viral exanthem, but it's a notifiable disease. So in that particular case, you need to notify the health security agency for that. So that's why it's very important that any child who presents with rash always look for the oral cavity as well. Sometimes you might get clues in the oral cavity as well. So this is viral exanthem, very common in infants and preschoolers, especially as we are into autumn and winter. You probably would be seeing more and more of these rashes. So usually these are associated with febrile illnesses. Let me show you another one. So look at this one. So this is a teenager, and this teenager has got a rash predominantly appearing on the back. Again, I mean, the picture, obviously, if the real patient is in front of you, you can examine the whole body, but it looks from this picture that's predominantly central, appearing on the back. And again, if you have got a magnifying glass and the actual patient is in front of you, you would see that this is basically, again, a maculopapular rash. So if you see this thing, again, as I said, your approach should be very methodical. You would always start by asking the right question and then learning the visual clues or describing the rash with its visual clues. So let's say this child has got history. You ask about fever. There is no fever. Has he taken any medications recently? No medications. Okay. Has he traveled anywhere? No travel anywhere. Has he got any history of allergies or exposure to something? No history of allergies. Any contacts who might be that elder sibling has got a cold, okay. What about himself? Any recent illnesses? Had a history of sore throat 2 weeks ago, which resolved on its own. Nothing significant. Visual clues. If you look and describe this rash, so again, as I told you, there are macules and there are papules. So it's a maculopapular rash. Predominantly, you could see it on the trunk, on the back, upper back and lower back. If you describe it, some of it is fine, some of it is coarse as well. So you see it's a mix of fine to coarse rash. Some of the lesions are coalescing into one another. It's symmetric. And if you see, I mean, they say if it makes any sort of a pattern or something, you see that it is discrete, but if you look, it looks like it's downward slanting in a form of a Christmas tree pattern. Pink color, downward slanting, Christmas tree pattern. So these types of rashes, maculopapular, where most of the times there's nothing else associated with that except that they might have an illness like a couple of weeks to months ago, and all of a sudden they come up in a rash. But other than that, they are absolutely fine. There is no fever, nothing, and they just like, it's more of like a cosmetic thing because you are all covered up in like these bumps and rash everywhere. This is what we call as pityriasis rosea. Some people say there is Harald starts with a Harald patch. I mean, in practice, it's very rarely you will see somebody starting with a Harald patch and then progressing to this Christmas tree pattern of maculopapular rashes. Sometimes it's just like one fine morning they wake up and then the rash appears and then it starts spreading, and 24 to 48 hours, most of the body is covered. Other than that, they are absolutely fine. So pityriasis rosea is like an sort of a delayed hypersensitivity reaction rash, usually type 4 hypersensitivity reaction, and there are different types of those. Most of the times it's caused by different type of viral illnesses. The only one thing is that sometimes in viral illnesses, like in infants, as they are still febrile, they come up in rashes there and then for the next couple of days, and then the rashes go away. Sometimes what happens is that virus clears off, but the viral antigen remains, and there is some of immunomodulation, like in response to those viral antigens, the way they are taken up by the helper T cells, presented to the macrophages, become activated macrophages, and then that sort of a battle, the skin becomes a battleground for these type of reactions, and we get what we call as a type 4 hypersensitivity reaction in the skin in response to different type of viral antigens, and this type of rash, it appears. So this is pityriasis rosea. Again, no treatment for these type of rashes, except I usually tell them that there's nothing wrong with these type of rashes, except that there is a cosmetic component to that. Obviously, they are looking at the self. It doesn't look fine if somebody's like fully coated up in a rash, especially more so when they are teenagers and they have got sort of a very much self-conscious about their appearance and everything. But usually, as you know, a hypersensitivity reaction doesn't happen in a day. Delayed hypersensitivity reaction, it takes like a couple of weeks to months before the thing, and it's the same goes for the sort of a resolution as well. Might take a couple of days to weeks before these rashes they clear up. If they ask, is there any like cream or medication? Nothing for these type of rashes. It's like a self-limiting condition. You just need to tell them that it will take few days to few weeks. Don't tell them it's going to go in the next 2 to 3 days. It doesn't. Like, it takes a while before it go completely go. Now the thing is that sometimes if you look, a slight change in the history would altogether lead to a change in the diagnosis. What if I tell you that if this child had a history of taking some medications a couple of days ago, and the same type of rash appears, then probably we would call it a drug rash. We've seen in practice many kids who have been like taking mostly antibiotics for some time, for some reason, and then like in the next few days they come up in a rash, and they are very much concerned. The parents are very much concerned. Even I've seen like they are being investigated by doing blood tests, and all you see is a high white blood cell count, or maybe a little bit of eosinophilia in the peripheral blood, and that is mostly because of the medications that are being taken. So the important thing is to stop the offending medication. So if they are, let's say, on some antibiotic, you have to stop that. If they are on any other medication which again might have led to that, again you can speculate. You just try to stop that and see if that improves the rash or not. So pityriasis rosea rash can be very similar to drug rash. Obviously there would be a history of drug, while in pityriasis rosea nothing, except that they had some illness couple of weeks to months back. So these two rashes can be deceptively similar to one another, but as I told you, if I ask the right questions, you would know what you are dealing with. So drug rashes, remember, if you do blood tests, usually they've got a high white blood cell count and high eosinophil count associated in most of the cases. Not in every case, but in most of the cases. Then want to show you something. Look at this child, okay, who has got a rash on the lower legs. So again, if you see this type of rash, you are only seeing a picture of the legs, but let's say this rash is also present on the hands, maybe on the upper arms or something. So you ask the right questions. So is there any history of fever? No fever. Any history of recent medication use? None. Has had any trouble? Well, they say no trouble, but had a school camp 2 months ago. But that was 2 months ago. The child has been fine since then. Any history of allergies or any exposures to any chemicals? No, nothing. Any contact at home which might be having a similar type of rash? Nothing. None. Any recent illnesses which the child had in the last like couple of days, weeks? No, none. So nothing. You're scratching your head. Now, if you describe this rash, so this is a rash which is predominantly present on the legs and arms. It is papular in nature because you can see that these are small solid bumps less than 0.5 centimeter, predominantly present on the lower legs and let's say arms. They seem to be symmetric because they are present on both sides. They are generalized because more than 2 anatomical areas are affected. It's peripheral, it's not central, because as you can see, it's close to the end of the periphery, so very close to the feet, very close to the hands, and it's non-coalescing. So these are discrete lesions separate from one another. They are not like sort of merging into one another. Bright pink in color and discrete. Now this type of rash, a papular rash, and if it is itchy, now here is the catch. If these type of rashes are quite common and they can have a wide variety of differentials to them. A papular rash predominantly on the peripheries, which is quite itchy. If the child is like, say, okay, then you have to think of, especially if there has been, let's say, some form of bug bites or insect bite or exposure to forest or something in the past, think of what we call as papular urticaria. So papular urticaria basically is just like, they look very much like insect bites or bug bites. But the thing is that there's no history of being bitten by these bugs or these insects. So if you ask them that, have you been bitten by something? They say, no, they've not been bitten. The thing is that they might have been bitten in the past, somewhere in the past. So again, this is nothing. This is just a delayed hypersensitivity reaction here to what? To the bite of those whatever bugs or insects. So their chemicals, when they injected, the body tried, sort of a delayed hypersensitivity reaction happened against them, and they come up in this itchy papular rash, mostly on the peripheries. Why in peripheries? Because most of these kids are bitten on the periphery. So it usually occurs in the periphery, and it's papular, it's itchy, and there is nothing else in this tree. There is no contacts. So we call it as what? Papular urticaria. Now, if the same type of rash and there is a history of contact, why I'm saying the context changes altogether. Same type of rash, but let's say if I change here that there are contacts at home with similar rash and it's itchy, then you should start thinking of scabies. You should start thinking of scabies. And if it is non-itchy, same type of rash, non-itchy and generalized, there is another term, we call it papular acrodermatitis of childhood, also known as Giannotti-Crosty syndrome, which let me show you. So look at this child. This child has got a papular rash predominantly, again, on the hand, on the wrist. You can't see the other one, but usually it's a generalized one. But this one is non-itchy. The previous one was itchy. This one is non-itchy. So a rash which looks like papular urticaria but is non-itchy, and the key here is non-itchy and is generalized, we call it papular acrodermatitis of childhood. This is there is a term for that. We also call it Giannotti-Crosty syndrome. So Giannotti-Crosty syndrome basically is just like papular urticaria but slightly more widespread and has got non-itchy component. And if there is a history of, let's say, contacts at home, itchiness, then you should think of scabies. And if the same rash has got an oral component, then you should be thinking of hand, foot and mouth disease. So what I wanted to emphasize here is that, see, you slightly change the context, the appearance is more or less the same. The appearance is more or less the same. You change the context and altogether the diagnosis changes. So it's not like papular urticaria or Giannotti-Crosty syndrome. If we take the context out, believe me, even like a dermatologist cannot, like on the face value, cannot sort of differentiate between the two. Yes, unless and until they do a biopsy of that, that's altogether. Histopathological diagnosis would be altogether different, but nobody does that for these types of rashes. It's mostly a clinical diagnosis. So the context and the visual clues, they matter. So a child who has got papular rashes, mostly on the peripheries, itchy, no contacts, possibly papular urticaria. If they've got contacts at home, possibly scabies. If it is non-itchy, no contacts, Giannotti-Crosty syndrome. And if they've got lesions in the mouth, the whole thing would be now called hand, foot, and mouth disease, which is called by Coxsackie virus. So just look how the diagnosis changes by simply changing the context. So that's why I want you to ask these questions and keep these differentials in your mind, so that like one thing changes, the diagnosis changes. So this is important. This is important. The context matters. That's why I told you, if you ask the relevant questions, you know the answers to that, you know how to describe it, in terms of visual cues, and you've got a few, about these terms. Okay, one of the common terms, though there are other diagnoses for these things as well. I'm just talking about the common ones. We cannot like cover the whole dermatology in 1 hour. I'm just talking about relatively common things in the differentials. So papular urticaria, scabies, zoonotic Ross syndrome, hand, foot, and mouth disease, they all present very like sort of a similar to one another. Only in the history, the context changes and the diagnosis changes. Just this thing is important. Keep this in mind. See here, this is a child, same child, okay, who has got like itchy papular rash, but they've got contact at home. This would be scabies. Now another type of papular rash. Okay, look at this one. So here is an image where you can see that there is papular rash with some scratch marks and erosions, predominantly on the elbows, on the extensor surfaces. And then the same child has got the same type of lesions on both knees as well. Again, so you say these are probably the pressure points and these are extensor surfaces, and you can see it's a predominantly papular. Maybe you can see a few vesicles and maybe a few pustules as well if you magnify it, and this is the rash. So if you ask the relevant question, this child has got history of no fever. This child has been taking Piriton because it's quite an itchy rash, and you can see a few scratch marks here and there as well. There's no history of travel. There's no history of allergies or exposures to anything. There's no other contact at home with similar rash. So obviously when there's no contact and an itchy rash, you are taking the scabies out of this equation. And in the recent illness, well, this child has got an issue of suffering from diarrhea on and off for the last so many months, years. When you look at the rash and describe, so it's predominantly present on the elbows and knee. It looks like it's papulovesicular in nature with a few scratch marks as well. Distribution is symmetric because it's present on both sides. It's localized because you can see it's present only on the elbows and on the knees. Peripheral because it's not present on the abdomen, on the back, or on the buttocks. It's a discrete rash and the color is bright pink. Now this type of rash, an itchy localized papulovesicular rash predominantly on the extensor surfaces. I mean, if again you would be scratching your head what this could be. Okay, papular rash, is it papular urticaria, is it scabies, is it zoonotic Ross syndrome? No. Look at the context. This child has got a history of diarrhea on and off, and this rash is predominantly where on the extensor surfaces. Zoonotic Ross syndrome, papular urticaria, they've got no sort of a predilection for extensor surfaces or something. They are usually present on both sides. This is what we call as dermatitis herpetiformis, usually associated with the gluten sensitivity. So some kids who have got celiac disease or celiac-like illnesses, they usually might have this presentation. This child has got diarrhea on and off, so probably needs to be evaluated for underlying celiac disease and some IgE abnormalities, because these type of rashes are associated with IgE abnormalities. And again, this type of rash, why we call it dermatitis herpetiformis, because this looks very much like herpes because there are vesicles as well, and it's quite itchy as well. And when they lead to erosion, then it becomes painful as well, because what happens is that there is exposure of the raw surfaces, and that would sting, whenever something touches with the raw surfaces. So these type of rashes, they do not respond very well to the treatment unless until you give them some dietary restriction, like gluten, sort of a gluten restriction of the diet, or sometimes dapsone has to be given to cover these. But obviously these type of rashes, you see them, you probably think about that, and they need to be further evaluated by the pediatricians to see if what other underlying abnormalities are present, because you have to correct the underlying abnormality to correct these type of rashes. So a papulovesicular rash on the extensor surface is very itchy, associated with diarrhea on and off, or sometimes there may be no history of diarrhea. Okay, so think of dermatitis herpetiformis. Again, not very common, I mean, dermatitis, but can happen, so you shouldn't be taken by surprise if you see any of these type of rashes.